All right, welcome to the deep dive. So you're here because you really want to get a grip on this whole endodontic irrigation and medicaments thing, right?
That's right.
And you've got this, pretty in-depth lecture material from Dr. Harry Mohan, right?
Yeah.
So we're going to kind of use that as our jumping off point.
That's it.
And today we're going to extract the really need to know info about how to clean and disinfect those root canals. Like what actually works, what does the research tell us, and why does this even matter, right? Why should you care about all this?
So think of it like, I guess, a shortcut, if you will. A shortcut to really understanding the core principles of endodontic disinfection.
Yeah.
We're going to tackle those big challenges that Dr. Mohan outlines in his lectures. Like, how do we really make sure we get rid of all the bacteria, especially when they're in those nasty biofilms?
Yeah.
And then how do we get rid of all the organic tissue in the canal system?
Yeah, all that gunk.
And I guess most importantly, how do we make sure that the cleaning and disinfecting agents that we use can actually reach every nook and cranny of that complex internal anatomy of the tooth?
Okay, so let's break this down. Where do we even begin? I guess we start with something that sounds really basic, but it's actually a huge obstacle, and that's biofilm, right?
So biofilm, what's really interesting about biofilms, and Dr. Mohan kind of lays this out really nicely in his lecture notes, and he references Nair's research from way back in 1987. It's their organization, right? So it's not just random bacteria floating around. These are dense communities of bacteria that actually adhere to the walls of the canal.
Ooh, they set up shop.
They're protected by this this matrix, almost impenetrable, we call it extracellular polymeric substance.
Oh, wow. So they've got a force field around them.
They built themselves a fortress, yeah.
That's wild.
And this makes them much more resistant to our usual antimicrobial strategies.
Right, because it's they're not just, they're not just out there. They've got this protection. So it's like you're saying, this really highlights how different biofilms are from your kind of, average everyday bacteria that's just floating around.
Right, exactly.
And this protective matrix that really makes them so much more resistant to, the things we normally throw at them to kill them off, the antimicrobial approaches.
Yeah, exactly. This matrix, it acts like a shield, right? And it prevents the irrigants and the medicaments from penetrating and ultimately doing their job.
So frustrating.
It's a huge problem. And, it's not just in the main canal. You find them in those little apical ramifications, those little branches at the end of the root.
Right.
You find them in the lateral canals and in the isthmus, that little connection between two canals.
Right.
These are all really difficult to reach.
Which then makes you think, how much can we actually rely on, what we see in lab studies, right? Because the lecture material was saying those in vitro studies, they often use single types of bacteria that are just floating in solution. They don't have this whole biofilm thing going on. And they don't really mimic the complexity of, the anatomy that we're actually dealing with when we're treating a real tooth.
Right. It begs the question, how applicable are these lab findings to the treatment that you're actually providing? That's a big question mark.
Huge. So what we're really getting at here is, just using our instruments alone, that's not enough to clean out these canals, right?
Absolutely not. It highlights the importance of irrigation, right? Flushing those canals with disinfecting solutions. It's essential to reaching those areas that our instruments can't.
Okay, got it. So we can't just rely on the files, we got to irrigate.
Absolutely.
Yeah, makes sense.
And, the numbers back that up. You look at studies like Bystrom and Sundquist back in 1981, they found that, even with really meticulous instrumentation, a good chunk of the root canal system remains untouched.
Yeah, what percentage are we talking?
At least 35%.
Wow. So over a third of the canal is still
untouched by our files.
Got stuff in it.
It's a huge reservoir for persistent infection.
Yikes. Okay, so that leads us to the next thing, right? You were mentioning this earlier, the smear layer.
Yes, the smear layer.
So tell us, what is that? How does that come into play here?
So the smear layer, it's essentially, it's a very thin coating that forms on the walls of the canal during instrumentation. It's a mixture of dentin dust, bits of pulp tissue, and of course, bacteria.
So it's all the byproducts of the cleaning process, basically.
Exactly.
It's like the dust bunnies.
And research from Sequeira Jr. and colleagues in 2018, that tells us that it's not just on the surface. It can actually penetrate quite deep into those dentinal tubules.
How deep are we talking?
Up to 40 microns.
Wow.
That's a long way.
That's deep.
Now, the question arises, does this smear layer act as a barrier? Does it actually prevent our disinfectants from reaching those tubules?
Where the bacteria are hanging out.
Hiding out, exactly.
That makes sense. Like if you've got all this debris, clogging things up, how's your cleaning solution actually going to get down there and do its job?
And that was a question raised by Hapasalo and colleagues back in 2010.
So what did they find?
Well, one interesting finding was that, the use of 17% EDTA, which we'll talk about in a bit, it had a limited effect on healing in initial root canal treatment, but a much stronger effect in retreatments.
Ah, okay. So it does seem like, in those teeth that have been treated before, getting rid of all that buildup, that's even more important for, the new treatment to take hold.
Absolutely. I mean, you're trying to clean a system that has already been filled once. So clearing that old residue, that's key.
Okay, that makes sense. So with all these challenges, the biofilms, the smear layer, all this stuff, like what are we actually trying to accomplish when we irrigate a root canal?
Right. So we're really aiming for several things when we irrigate.
Lay it on me.
Okay, so first, we want to lubricate the canal walls during instrumentation. This helps to prevent instrument breakage, helps things move smoothly.
Right, got it.
Second, we want to flush out debris, those dentine filings, tissue remnants, everything we're creating with our files.
Okay, so it's like a physical cleaning process as well.
Absolutely. Number 3, we want to dissolve the organic matter.
So that's like getting rid of any remaining pulp tissue.
Exactly.
That could be a source of food for bacteria.
Exactly.
Got it.
Then number 4, we want to dissolve the inorganic matter. So that smear layer we talked about, we need to remove that.
Okay.
And then number 5, perhaps the most obvious, is to destroy the microbial organisms, the bacteria that are present.
Kill the bugs.
Kill the bugs. And finally, number 6 is to clean those areas that our instruments just physically can't reach.
Because of that complex anatomy we talked about.
Right.
Okay, so it's not just about killing the bacteria, it's about this whole multifaceted approach.
Exactly. To cleaning, dissolving, lubricating the whole system.
Okay, that makes total sense. So let's talk about the tools then. What are the actual irrigants that we use? In the lecture, Dr. Mohan talks about sodium hypochlorite, chlorhexidine, EDTA.
Yes.
So let's start with the big dog, right? Sodium hypochlorite, NaOCl.
NaOCl, this is the one everyone's familiar with.
Yeah, it's the classic.
It's got a long history. It goes all the way back to Udakin's solution.
Wow.
Used in World War I to disinfect wounds.
That's pretty impressive.
It's a broad-spectrum antimicrobial, so it's effective against a wide range of microorganisms.
So we're not just talking bacteria here.
No, we're talking spores, fungi, protozoa, viruses, the whole lot.
Wow.
It's a powerhouse.
And it doesn't just kill them, right? It also dissolves tissue, which I'm guessing is incredibly helpful for getting rid of any, leftover pulp tissue.
Absolutely. That's a key property of NaOCl. Oh. Very effective at dissolving organic tissue.
Okay.
And of course, it's cost-effective, it's readily available, and it's got a pretty good shelf life.
Which is important, practically speaking.
Right. Now, chemically speaking, when NaOCl is mixed with water, it dissociates. So you have sodium ions, you have hypochlorite ions, which then form this equilibrium with hypochlorous acid.
Okay, getting a little sciencey here.
Yeah, well, it's important to understand how it works, right? So both the hypochlorite ion and the hypochlorous acid, they're potent oxidizing agents. And that's what really gives them their antimicrobial activity.
They just break down the bad stuff.
Essentially, yeah. They disrupt those essential molecules within the microbial cell.
Got it.
And the solution itself is fairly alkaline with a pH of around 12 to 12.5.
Wow, that's pretty basic.
Very basic. So there's a lot of research on NaOCl. Bystrom and Sundquist, back in 1983, they show that even a low concentration, like 0.5%, was way more effective than just saline.
Okay, so it's really doing something.
It is. And then in 85, they found that 0.5% and 5.25%, they were actually equally effective in terms of reducing bacterial counts.
Really? So even a much higher concentration didn't really make a huge difference?
In terms of the final bacterial count, no.
Interesting. So you don't necessarily need to go super high.
Right. However, one important caveat. If you're not placing an inter-appointment dressing, a medicament in the canal between appointments, you can get bacterial regrowth.
So they can multiply back up.
Pretty quickly.
Oh, that's a problem.
So, either you need to be really thorough in a single visit or use an effective medicament if you're doing multiple visits.
Okay, so those are the two options.
Right. Now, you mentioned tissue dissolution.
Right. It's not just about killing the bacteria, it's about getting rid of all that other gunk, right?
Exactly. And Hasselgren, back in 88, he showed that NaOCl is very effective at dissolving that organic tissue. And, Stojicic and colleagues in 2010, they found that agitating the NaOCl was actually much more effective than heating it.
Interesting. So moving it around is better than just turning up the heat.
Exactly. And, in a clinical setting, controlling the temperature inside a tooth is very difficult.
Yeah, I can imagine.
And any heat that you do apply is going to dissipate really quickly.
Okay, so agitation is key.
Agitation is key. Now, we've got these things called surfactants.
Right. Dr. Mohan mentioned those in the lecture. What do those do?
So the idea is that they reduce the surface tension of the liquid.
Okay.
And that increases its wettability. So theoretically, it can penetrate deeper into the dental tubules.
Right. But the research on that, I think you mentioned earlier, is kind of, mixed.
Yeah, the evidence isn't really strong.
Like, does it really make a difference?
Yeah, we're not really sure. And some surfactants might even break down the NaOCl faster, which would reduce its effectiveness. So that's something to consider.
Okay, so NaOCl, it's powerful, but it's also got a bit of a warning label, right?
Absolutely.
Dr. Mohan talks about how it can cause some serious problems if it escapes the canal.
It's highly toxic.
Right. Like, what kind of problems are we talking?
We're talking ulceration, hemolysis, even necrosis.
Wow.
And this is usually dose dependent. So
Right.
the higher the concentration, the greater the risk.
Right. And most of the incidents happen with that higher concentration, the 5.25%.
That's right.
And they're called hypochlorite accidents, right?
Unfortunately, yeah.
Those sound pretty awful.
They can be. Rapid swelling, intense pain, possible sinus involvement, bleeding, nerve damage, even secondary infections.
Yikes.
And they tend to happen most often in the maxillary molars and premolars.
Makes sense because those are closer to the sinus.
Exactly.
So prevention is key. What can we do to prevent these accidents from happening?
Okay, so first of all, always use a rubber dam.
Okay.
Always.
Got it.
Carefully place your needle, make sure it doesn't bind.
Right.
Measure your working length. Don't go all the way to the apex.
Okay.
Irrigate gently. And if you suspect a perforation, be extra cautious.
Be super careful.
Now, if it does happen, if a hypochlorite accident occurs, immediate management is key.
Okay, what do we do?
Okay, first and foremost, you tell the patient, keep them calm.
Right.
Irrigate the area with saline.
Lots of saline.
Lots of saline.
Dilute it?
Dilute it. You can apply a cold compress.
Okay.
Manage the pain. Give them analgesics.
Got it.
You might need to drain any fluid or blood.
Okay.
Place a medicament.
Okay.
Make sure you've got a good coronal seal.
Got it.
And consider antibiotics if there's a risk of infection.
Okay.
Now, if it's a severe case, airway obstruction, or they've ingested the solution, that needs immediate referral.
To an oral surgeon.
Absolutely.
Okay, so take this seriously.
Very seriously.
Okay, so that was NaOCl, a lot to think about there.
Yes.
Right. Let's move on to chlorhexidine.
Chlorhexidine CHX.
So CHX, this one works differently than NaOCl, right?
Right. It's got a different mechanism of action.
Okay, how does it work?
It binds to the negatively charged surfaces of bacteria, and it disrupts their cell walls, causing leakage.
So it basically makes them explode.
In a way, yeah. It ruptures them.
Okay.
Now, one downside is that its activity is reduced in the presence of organic material.
So, if there's still pulp tissue in there?
Exactly. It's not as effective.
Okay. But it does have that substantivity thing you mentioned earlier.
Right. Substantive.
So remind me, what does that mean?
It means that it binds to the hard tissues in the canal.
The dentine.
The dentine. And it can continue to be released over time.
So it has a longer lasting effect.
Exactly.
That's cool.
But it doesn't dissolve tissue like NaOCl does.
Okay, so it's good for one thing, but not for the other.
Right. And it's generally considered to be less effective overall than NaOCl.
Especially against those gram-negative bacteria.
Especially against gram-negatives, yeah.
And there's that issue with the precipitate.
Right. If it comes into contact with NaOCl, it can form this precipitate called parachloroaniline, which is potentially toxic.
And mutagenic. So
you definitely don't want to mix them.
Definitely not. And some studies even suggest that it could worsen the long-term outcome, right?
Yeah, there's some evidence to suggest that.
So if you're going to use both, you have to use them sequentially with lots of rinsing in between.
Exactly.
I got it.
So moving on to EDTA.
EDTA, this one is all about the smear layer, right?
That's right. It's great for removing that smear layer.
Okay.
So it works by reacting with calcium ions.
Okay.
And it forms these soluble compounds called chelates.
Right. And that basically dissolves the calcium hydroxyapatite, which is what the dentine and the smear layer are made of.
Precisely.
Okay, but it doesn't really have much antibacterial effect on its own, right?
No, its main job is to remove that inorganic material.
Got it.
But research has shown that using 17% EDTA for 1 minute, followed by NaOCl, that's a very effective protocol for removing the smear layer.
Okay, so they work well together.
They do.
But you don't want to leave the EDTA in there for too long, right?
Yeah. No, because it can demineralize the dentine.
Weaken the tooth.
Weaken the tooth, exactly.
Okay.
And it can also interfere with NaOCl.
So again, sequential use, lots of rinsing.
Exactly.
Got it. Now, there were a couple of other irrigants that Dr. Mohan talked about, like Q-Mix.
Right, Q-Mix.
What's the deal with that one?
So it's a newer irrigant. It's marketed as a one-step smear layer removal and disinfectant.
Okay.
It's got EDTA, chlorhexidine, and a detergent.
So it's like a 3-in-1?
Yeah, kind of. And studies have shown that it's pretty good at removing the smear layer.
Comparable to EDTA.
And it's also got decent antimicrobial activity.
Okay.
So it's a promising option.
Got it.
And then there's Triton.
Triton, this is another newer one.
Yeah, it's a 2-part solution.
Okay.
It's got chelators, surfactants, and you mix it with 8% NaOCl.
To get 4%.
Yeah.
So it's pretty concentrated.
It is. However, the research on this one is a bit mixed.
Ah, okay.
Some studies show it's good at removing the smear layer, others not so much.
So jury's still out on that one.
Yeah, more research is needed.
Got it. So it sounds like the classic combo of NaOCl and EDTA, that's still the gold standard.
Right. Used sequentially with proper rinsing, it's very effective.
Proven track record.
Now, it's not just about the irrigant itself, right? It's also about how you deliver it.
Yeah, how you get it in there.
Exactly.
And how you move it around.
Agitation.
Agitation, right.
So needle design, that's important.
Okay.
You've got open-ended needles, closed-ended needles.
What's the difference?
Open-ended needles, they create a jet of fluid,
Okay.
but they also have a higher risk of extrusion.
Pushing it out the end.
Right. Closed-ended needles, they're safer, but they might not be as effective at reaching the apex.
Okay, so there's a trade-off there.
There is. And then there's the gauge of the needle.
So like how thick it is.
Right. A smaller gauge means a wider needle, which means faster flow.
Okay.
And importantly, irrigation needles are not as flexible as our files.
Makes sense.
So you have to be careful in curved canals.
Okay.
You don't want to bind or perforate.
Got it. And then there's this thing called vapor lock.
Vapor lock, yes.
What's that all about?
So it's basically when you get air bubbles trapped in the canal,
Okay.
and that can block the irrigant from reaching the apex.
Ah, so frustrating.
It is.
So how do we prevent that?
Well, you can make sure you create a sufficient apical preparation.
Okay, make it wide enough.
Right. You want to place your needle as close to the apex as possible without binding.
Okay.
You can use an open-ended needle, but again, be careful of extrusion.
Right.
And you can use a higher flow rate,
Okay,
which usually means a larger gauge needle.
got it. So the goal is to create a nice clear path for the irrigant to flow all the way to the end.
Exactly.
Makes sense. Okay, so now let's talk about agitation techniques.
Yes, agitation. This is where things get really interesting.
Because it's not enough to just put the irrigant in there and let it sit, right?
Right. We want to move it around, create some turbulence, help it penetrate.
Okay, so what are our options?
Well, we have manual agitation, which is just moving a gutta percha cone up and down in the canal.
Okay,
That's very simple, very effective.
easy to do.
And then there's passive ultrasonic irrigation,
All right.
PUI. This is where you use an ultrasonic tip in the canal,
Okay.
and the vibrations create acoustic streaming and cavitation.
Wow, that sounds fancy. What does that mean?
It basically means that you create this swirling motion of the fluid, and you get these tiny bubbles collapsing.
Okay,
And that helps to dislodge debris and disrupt biofilms.
cool.
But you don't want the tip to touch the walls too much.
Why not?
It can actually dampen the effect.
Ah, okay, so you want it to be free floating.
Exactly.
Yeah.
And you need to replenish the irrigant regularly.
Okay.
Now, there's also sonic activation.
So sonic activation, so that's different from ultrasonic.
Right. It uses a lower frequency vibration. And there are different devices for this. You've got the endoactivator, which has a polymer tip.
Okay.
And then there's ED-DWE, which has a polyamide tip and uses air scalar.
Okay, so those are two different options.
Right.
Got it.
And then we have laser disinfection.
Laser disinfection, now we're getting really high tech.
Right. So this uses lasers like water laser or light walker,
Okay.
and they can induce cavitation in the irrigant.
Okay.
And they've been shown to be very effective at reducing bacteria, smear layer, and debris.
Okay, but there's not a lot of clinical evidence yet to say they're better than the other methods.
Right. That's the caveat.
Okay.
And they are expensive.
Yeah, that's a factor.
So the jury's still out on that one.
Okay.
And then finally, you've got these comprehensive systems like Sinendo or Gentle Wave.
These are like the all-in-one system?
So, right.
Okay.
They use multisonic frequencies.
Okay.
And they irrigate with NaOCl and EDTA.
Okay.
And they don't require a lot of instrumentation.
So you don't have to shape the canal as much.
That's right.
Uh-huh.
But again, there's not a lot of long-term data on these.
Okay.
And they can be prone to NaOCl accidents.
Right, because they're using high concentrations.
And they're expensive.
Okay, so lots of options, but the classic methods are still pretty good.
Right. PUI, manual agitation, those are still very effective.
Proven track record. Okay, so we've talked a lot about cleaning the canals with irrigation.
Right.
What about medicaments?
Medicaments.
So those are the antibacterial or anti-inflammatory things we put in the canal between appointments.
Exactly.
Right.
So they have several purposes.
Like what?
Well, they prevent recontamination.
Okay.
They provide ongoing disinfection.
Okay.
They can help dissolve any remaining tissue.
Okay.
They can promote hard tissue formation in some cases.
Okay.
And they can help manage pain.
Okay, so they've got a lot of jobs to do.
They do.
And the most common one is probably calcium hydroxide?
KOH2 or CH.
Good old CH.
The workhorse of endodontics.
So tell me about it. How does it work?
Well, it's very alkaline.
Oh.
You've got a pH of about 12.4.
Wow, that's high.
And it works through alkaline hydrolysis.
Alkaline hydrolysis, what does that mean?
It means that it basically disrupts the essential molecules in bacteria.
Proteins, fats, DNA, all that stuff.
Exactly.
Okay, but it's not always 100% effective, right?
Right.
Like, what affects how well it works?
Well, the buffering capacity of dentin, for example.
Okay.
The amount of organic tissue that's still present.
Okay.
The duration of exposure.
Okay.
And the size and density of the dentinal tubules.
So it's a complex environment.
It is. And interestingly, when you look at the research comparing single visit versus multi-visit endodontics, there's not a huge difference in success rates.
Really? So is CH even necessary?
Well, for routine cases, maybe not.
Okay.
But for complex cases, it's still very important.
Like what kind of complex cases?
Well, incomplete root formation, large apical foramina, retreatments, resorption lesions, things like that.
So it's not a one-size-fits-all approach?
Exactly.
Okay. What about postoperative pain? Does CH help with that?
Most studies say no.
Really?
Yeah, it doesn't seem to have a significant effect on pain.
Interesting. So oral analgesics are probably better.
Probably.
And how long do you need to leave CH in the canal for it to be effective?
At least a week.
A week?
Yeah.
Okay.
And the pH can remain high for a long time.
Really? Like how long?
Up to 12 months in some cases.
Wow, that's a long time.
So it's got a lasting effect.
Okay. What about chlorhexidine gel as a medicament?
Not very effective.
Really?
Yeah, studies have shown that it doesn't really do much in vivo. And there's still that risk of precipitate if you mix it with NaOCl.
Right.
And it doesn't dissolve tissue or neutralize LPS.
So not a great option.
Not really.
Okay. Let's move on to letter mix.
Letter mix.
So this is the one that might help with pain, right?
That's right.
Okay. Tell me more about it.
So it's a combination medicament.
Okay.
It's got dimethylcycline hydrochloride, which is an antibiotic,
Okay.
and triamcinolone acetonide, which is a corticosteroid.
Okay.
And it's in a PEG base.
PEG, that's polyethylene glycol, right?
That's right.
Okay.
Now, its antibacterial effect, there's not a lot of research on that.
Oh,